cords into vibration, and voice happens. Normally, there's this amazing continuity between the pressure forces of the vocal cords and the pressure coming up from our lungs. And so I'm speaking to you now with probably only about maybe 5 or 10 cc's of water pressure. You know, that's not very much. That's only about that much pressure in a column of water. And that's able to, when I close my vocal folds with just enough force, that the pressure from my lungs is able to set it into vibration. And the vibration is very similar, believe it or not, to what would occur if you were to blow up a balloon and let it fly around the room. It would make noise. The vocal cords actually vibrate in a very similar pattern to that. It's kind of vibration in viscoelastic tubes that are partially collapsed. But for some reason, in spasmodic dysphonia, at least the adductor variety, the pressure of the vocal cords is a little too much at times for the pulmonary expiratory force. And the voice gets stuck and sounds very tight and strained. And that's really what we're trying to treat. Now, it's interesting that for a long time, the NSDA and clinicians such as myself kind of like to pigeonhole exactly what type of disease process an individual had with SD, whether they have an adductory variety, abductory that Dr. Bastian has very nicely described to us. There are other varieties of this disorder that were called adduction with compensation, abduction with compensation, functional or psychogenic, plus minus tremor, whether the patient with SD had muscular tension dysphonia on top of it. But I think what's happened now after many years of trying to describe the entity in detail is that we've come to the impression that it's a voice disorder that's neurologically based, that can have a variety of symptoms associated with it. And probably what we should say is a voice disorder that responds to botulinum toxin or doesn't respond to botulinum toxin is kind of a criterion to describe it, because many of you with complex voice disorders don't really fit neatly into any of these nice, easy pockets that we've tried to develop for the condition. And so I think it's important that we start to change the way that we're thinking about this disease process a little bit. And the etiology, as it were, it's still pretty much an idiopathic disease. We don't really stand the etiology. It's thought to primarily be a central disorder, and you're going to hear about a lot of the really great research that's going on. It seems to be that there's a lot of feedback that goes to the brain that causes some inhibition that somehow is not functioning properly. And I'm not going to go into that because I don't really have the time, but you can almost develop a variety of different ways of looking at the same disease process. It can be something that's related to the afferent system. It can be a central organization. You can even see it as an end organ, just in the larynx itself. And so I think what we're looking at are these phenotypes that may have a number of different causes to them as well. And so again, I think we need to expand the way that we think about this disease and not assume that everybody that has spasmodic dysphonia has the same etiology, the same cause of it as well. So, here's a little pointer. So, yeah, you can see that. So the nerve that comes into the larynx comes up and gives off a branch to the muscle that opens the vocal cord, and then kind of extends on towards the front of your larynx and ends in the stellate configuration. And that's actually in the muscle of the vocal cord itself that we call the Thyroarytenoid Muscle. And we can actually find that nerve, believe it or not, through, let's see, where's my little pointer? Here it is. Through little windows that we cut. In God's infinite wisdom, He actually put the nerve right under the thyroid cartilage. This is just another diagrammatic representation of it. Nerve coming out, giving off this branch. And it gives off a number of branches to the other intrinsic muscles of the larynx. These are all muscles. We call them extrinsic muscles and intrinsic muscles. These are all muscles inside the larynx. But all the muscles that attach to the larynx can have an impact on the way the larynx functions and the way that sound is produced. Just coming up and actually giving off the branches and the branch continuing on as well. There is some variability, but for the most part, the nerve as it enters the larynx divides into a red wire that opens the larynx and a white wire that closes the larynx. And you can trace that all the way back to the brainstem. You can find cell bodies in the brainstem that are organized as well into opening cell bodies, closing cell bodies, and cell bodies that go to the individual muscles. And in a normal situation, believe it or not, we have individual control over almost all the intrinsic muscles of the larynx. When we alter those, we can make the voice tight, we can make the voice loose, we can make it go up high, we can make it louder, and all of those are controlled by these individual cell bodies in our brainstem, and of course the cortex that feeds down to them. So the treatment for adductor spasmodic dysphonia, or maybe I should erase the word adductor and just say spasmodic dysphonia, pretty much divides into these categories. There's 4 main categories that we think about: speech therapy, section of the RLN, or actually cutting the nerve or changing the nerve, Botox injection into the thyroarytenoid muscle, and laryngeal framework surgery, actually operating on the skeleton of the larynx itself, the cartilage that has the muscles attached to it to alter speech. So speech therapy. So for the most part, and I think Dr. Bastian alluded to it as well, for a long time the disease was thought to be a psychogenic disorder, and now I think we understand that indeed it's a neurologic disorder at best and has very little psychogenic impact associated with it, except occasionally you'll find a patient that still has some type of conversion disorder going on and trying to cause a bad voice. And speech therapists, if they work diligently with patients, can actually do pretty well. They can actually help. The problem is when patients are trying to speak extemporaneously and don't have the time to think about the words that they're saying, they run into problems because there just isn't enough time when we're kind of thinking about how to express ourselves to worry about how are we going to say this word, what's it going to sound like. Again, a few speech therapists for many, many years have confused functional dysphonia with true spasmodic dysphonia. We used to have a speech therapist in Los Angeles who was actually quite famous and had a TV show. And whenever he would do his TV show, he would have these functional people that he treated that were better. And he would always somehow invoke my name on this little local TV show. My daughter would sit down and I'd be saying, hey, Kristen, look at this TV, this guy's going to say my name in about 2 or 3 minutes. And sure enough, the guy would always, she's like, how do you know that, Dad? I said, I can't go into that. So most patients with spasmodic dysphonia obviously don't improve that much with it. But I can tell you that many of you are here because you have fairly complex voice disorders. For whatever reason, doctors haven't been able to help you with standard therapy. And I think under those circumstances, it's probably not a bad idea to see a voice therapist and see whether there are some elements of your voice disorder that they can help you with. They may not be able to help you with all of it, but there may be some aspects of it that they can actually correct. So Botox has been around for a long time. Dr. Blitzer and Ludlow did some early studies and showed that it was very useful. Oromandibular dystonia, myoclonus, hemifacial spasm, hyperfunctional facial lines. Since hyperfunctional facial lines have kind of come into vogue, the Allergan company that makes Botox's stock has kind of gone through the roof. And whether that's good or not, I don't know, but you realize that in order to make us spend as much as we possibly can, they actually write on the bottle for single use only. And so whenever we open up a bottle of Botox, if we were actually to do that, it would be $600 per patient that we would have to spend just on the medicine alone, which is really not very fair to you guys at all. And so many of us don't listen to that, but nevertheless, if you're in a situation, that's what Allergan has put on their bottle. You can use lidocaine 10,000 times, but for Botox, no, only 1 dose. So the Botox acts presynaptically, that is to say before the nerve actually goes to the muscle, and it inhibits the release of acetylcholine, which causes the muscle to contract. Blitzer initially gave a unilateral injection of 15 units to some patients, which is a big dose, but that's before the Botox was actually reconstituted. It's much stronger now than it used to be when those initial studies were done. And he noticed there were decrease in pitch breaks and aperiodicite, and it worked quite well. It was almost an unbelievable treatment for a disease process that hadn't been really effectively treated at all. Your technique and doesn't really hurt you when they do it, or doesn't spend an excessive amount of time or charge you an excessive amount of funding to do it, then you ought to stay with that. Personally, I think my advice has always been, before a patient comes in, you're already poking them in the neck. I wanted to develop a technique that I thought would be the least invasive, take the least amount of time, and so we use something that's called the point touch technique, which means that we point to where anatomically the nerve should be, and then the rest of the injection is actually through touch. I should have called it the Gerald Berke technique, but I thought, I'll just call it the point touch. And basically, we usually try and go cartilaginous right through the vocal cord. You can see, and it's once you learn how to do it, it's not difficult. There's a, everybody's neck is a little bit different. Some people have calcified cartilages. Some people are fatter in their neck. Some people, their larynx is high, the larynx is low. So there's a lot of permutations that you have to learn. But once you learn those, it's a pretty easy type of injection to do. And we can actually go underneath as well if we need to get into the vocal cord. And despite some people that say EMG is the gold standard for injecting Botox, the nerve actually is pretty far back and pretty lateral, that is to say pretty much to the side. And so just because you have a really strong EMG signal doesn't mean that you're actually close to the motor end plate where you want the Botox to have its most effect. Nevertheless, if somebody's really good at an EMG injection, I think they should continue to do that. Adductor SD is another type of injection in which we actually have to inject the Botox into the muscle in the back of the larynx, behind everything, that actually the vocal cord. And so there's two issues with that, two problems with that. One, that muscle happens to be very highly protected by cartilages all the way around it. It's all the way in the back of your throat as well. And so you either have to go through the backside of the cartilage to get to it, or you have to turn the larynx 90 degrees to get to it from the back. It can be very difficult to do, and many patients with adductor SD or part of an adductor type of picture in their spasmodic dysphonia don't get much relief from Botox shots. And the reason for that is that there's a very fine line between paralyzing the muscle enough to allow the larynx to close more easily and patients not to sound breathy, and giving too much Botox so that patients actually can't open their vocal cords to breathe. And so there's a very fine line between that, and it makes it very difficult for clinicians to treat patients with the adductor variety or for the breathiness that you see in many of these patients. How much to inject? I don't think really it's that pertinent to go into this. Sometimes I talk to doctors about that, but I think it's important to say that some patients can actually have breathiness or aspiration. There seems to be a relationship between the length that the Botox lasts and how many side effects are present. So some patients don't want to come in to see me very often. They'll get a very large dose. They'll be breathy for a month to 6 weeks, but the dose can last as long as 6 months. Other people, especially men in work, don't have the opportunity to wait 6 weeks to get their voice back. They just want a little shot, maybe on one side, under which it may only last 6 weeks, so they have to come in more frequently. So every patient is a little bit different, and it has to be kind of titrated to what their needs are. As I said, unilateral injections, bilateral injections, breathiness. There's a tremendous therapeutic range. You know, when you take a pill, you might take a 5 milligram pill, or if you really want a strong dose, you might take a 10 milligram pill. But for Botox, the range can be all the way from something on the order of 1/8 of a unit, 1/16 of a unit, all the way up to 5 or 10 units. There's very few medicines that we use in our practice that have such a large therapeutic range, and we have to tailor that range for every single patient. Every single patient is different, And as I said, and then when you, on top of that, you put their own qualifications as to what types of breathiness they're able to endure, it makes for a very different treatment protocol for each and every patient. Occasionally, patients can develop antibodies. I think I've seen it twice. There was a lady that came to see me a long, long time ago that around Christmas time, and she said, you know, I need 100 units in my local office. I said, whoa, 100 units? I don't give 100 units. She said, no, I don't understand. I have antibodies to Botox, and I need a really, really large dose to get any effect. And lo and behold, I gave her 100 units, and she got a mild effect from it. But you see it very seldom. You can actually, if someone is concerned about that, you can actually mail your blood away. There's a couple places that will check for antibodies. I think they almost never occur. And when patients come in and say, gee, Dr. Berke, you know, the Botox isn't working on me anymore. You know, it used to work, but it doesn't work, or I had one good shot and it doesn't work. So in the patient's mind, he's thinking, this is bad, Botox is bad. It doesn't really work on me anymore. But in my doctor's mind, I'm thinking, the doctor that gave you this Botox isn't familiar with the best way to inject it, and you're probably not getting a proper type injection from it. Maybe you ought to try another center and see how they do. Although some patients can come in and say, God, I've been all over and I still can't get a good result. That's another kettle of fish. So there's so many forms of Botox now, and this slide is probably a little bit old, but there's two forms of Botox that we frequently use. There's Botox A, made by Allergan, and Dysport. And about 1 unit of regular Botox from Allergan is about equal to 6 units from Dysport. And because of that, as you start to increase the dose, you get closer to the toxic dose of it. And so if you can use the Allergan Botox, it's a little bit safer than the other varieties. Of course, there's a Botox B that you can use for the few patients that do have antibodies to Botox, and there's even a Botox F. But as I said, because Dysport and Botox B have less effectiveness compared to the toxic dose, they're not quite as safe to use. But and in fact, there was an otolaryngologist or two that was actually buying experimental Botox on the internet and giving it to their patients. Fortunately, they're now in jail. So who should perform these injections? I think it's important to understand that a laryngologist that's familiar with giving Botox needs to know only one piece of information. Needs to know what were the doses, how many units did you receive. He doesn't need to know how did the doctor dilute the Botox, what was the needle like, because those questions tell you and tell me that the doctor that's about ready to give you the shot doesn't really know how to inject Botox. And so the only real question that I think is pertinent to the discussion is how many units have you had in the past? So is Botox an intermediate therapy or a final solution? I would say for those patients that are continuing to get relief of their symptoms, find that the doctor is doing a good job. Maybe not every time is perfect, but for the most part, most of the time, everything works out well. Is kind of happy going there, is not spending a fortune on it. I think that you should continue to get Botox because I think it's the appropriate thing to do. And it's probably overall the least invasive. But as with anything, sometimes things don't work very well for patients. They're not near an area where they can get Botox very easily. Or for whatever reason, it's costing them a fortune, or the doctors in their area just aren't very familiar with how to use it. Those patients sometimes start looking for other alternatives. So these are some of the reasons that patients do that. They just wanted a cure. There really is no cure for SD. Even with the surgeries, when they work very well, we're not really curing the SD. We're kind of rearranging the green wires and the red wires and the white wires so that the voice doesn't sound as tight, but we're not really curing the disease. And in fact, when I listen to somebody with SD, even after they have surgery and it's immediately successful and wonderful, I can still hear some disorder in their vocal production. You guys might not be able to, but I can still hear an underlying problem. The ups and downs of Botox, prolonged voice difficulties after Botox stopped working, cost of Botox, swallowing difficulties, Botox never worked, and difficulty with traveling to obtain Botox. So there's been, for a long time, patients trying to develop surgical analogs of Botox. And Dr. Ashiki, who was a brilliant plastic surgeon, he's actually not an otolaryngologist, but he's a brilliant researcher and has really done tremendous amount for the subspecialty of laryngology. Has developed a couple of different surgeries to treat spasmodic dysphonia of varieties. Anterior commissure pushback, that is to say, he would make incisions into the cartilage and push the front of the cartilage back to try and take tension off the vocal cords. When that didn't always work, and I can tell you that it doesn't work very well, he would try opening the larynx like this and putting a shim in to kind of widen it. The problem being that oftentimes doesn't work. And then for a different type of disorder, the abductor variety, actually pushing the vocal cords a little bit closer together. Other surgeries that have been tried actually involve cutting the muscle itself, the muscle of the vocal cord where a lot of the problems occur. And then a number of different operations that involve trying to change the innervation that goes to the larynx, trying to change the way the muscles are innervated by the body. And again, the muscle is pretty much divided to a back muscle, which opens the larynx, and all the other muscles pretty much close the larynx and provide tension. So in your mind, if you're interested in that, you can keep that division apart. So I'm going to talk about a little bit about laryngoplasties. And I think the main problem with laryngoplasties is, number one, it's not a cartilaginous problem. It's not like there's something wrong with the cartilage of the larynx. It's a neuromuscular problem that's causing the issues that most of you guys are facing. And restructuring the cartilage isn't really getting at the heart of the problem, and the body typically finds a way to get around that as well. A bigger problem with that is that almost all the cartilage procedures that exist require that some type of metal shim is put into the larynx, either to hold the commissure back or to widen the larynx. And the net result of that is that there's scarring in the front of the larynx, and the scarring makes it very difficult to inject Botox if the surgery isn't successful. So you've kind of obligated yourself then to just have surgery and never really be able to do very much with it if you don't get a good result from that. And at least in my hands, I never really found that it worked very effectively. There you can see there's different ways of recarving up the cartilage, but again, it's not a cartilaginous problem, it's a neuromuscular problem. Now, there is one type of SD, the abductor variety, where the vocal cords have difficulty closing fast enough that for some reason seems to respond in quote-unquote mild cases. You know, some people that have really bad abductor where instead of saying help, they go because they have trouble closing their larynx from the aspirated H to the L sound. So there's a delay, and you hear that in their voice as help. For some reason, if they have a mild case of that, if you can move the vocal cords a little closer together by pushing them closer together, it helps them get around that, whether it's a somatosensory issue or whether it's just a timing event. I don't really know, but nevertheless, they can gain a better voice. And for patients with a mild abductor problem, it might be worth looking into that as an alternative. Going on to myomectomies. This is the process of where we actually cut the muscle in order to remove some of the hypertonicity that exists in it. And there have been a number of people that have published papers on it. There have been a number of people that have tried to cut the muscle, whether or not they actually did publish their results or not. And there have been a couple papers on cutting the muscle in the back, the PCA muscle, the muscle that opens the vocal cord for patients with the abductor variety of spasmodic dysphonia. And again, I think at UCLA, I probably treated 10 patients with it, and now maybe more, of which I think not that many of them actually improved. And part of the problem is it's the same thing with Botox, basically. the endpoint between cutting too much and not cutting enough is very hard to know. And so we don't really have a good treatment for the abductor variety until we get to the point where we're able to actually look at some of the other issues that are actually causing the brain abnormalities. There's the TA muscle right underneath the cartilage, and so it's not hard to access that muscle through a window. And as I said, cutting the PCA muscle, it can be a worrisome event. Going on to denervation, reinnervation procedures. You know, Dr. Dito was the first person that actually demonstrated. We kind of criticized Dr. Dito because he cut the recurrent laryngeal nerve. But he was the first person that actually demonstrated that this wasn't a psychogenic disorder. Not all these patients that had spasmodic dysphonia weren't crazy, they weren't functional. They actually had a neurologic disorder, and he demonstrated that because when he cut the nerve, the patients got better, and they wouldn't have had it just been some kind of psychogenic process. But unfortunately, a high percentage of those patients recurred for two reasons. Number one, when you cut a nerve, it has a tendency to try and grow back together again. And number two, he could only do one side because if you cut both sides of the recurrent nerve down in the neck, you also cut the fibers that go to the opening muscle, and the vocal cords would be closed and you wouldn't be able to breathe. So you can't do both sides. Using this type of approach. Dr. Neneville actually tried emulsing the lung portion of it. Some patients were very breathy, and then he tried medializing those patients, and some of them had return of symptoms. A guy named Iwamura back in Japan reported doing a unilateral selection of the RLN, but he never reinnervated it. You know, Japan has a lot of patients that they show you with SD that they treat, but the disorder is very rare in Japan. So you have to have a bit of skepticism when you see somebody with spasmodic dysphonia in Japan that responded well to an operation. You're not really sure what they're responding to. So we took advantage of what I might call an advanced understanding of the anatomy of the larynx. And surprisingly enough, back in the, let me see my little arrows. Back in the 80s were the first papers. The 80s aren't that long ago. You know, we had already landed a guy on the moon and walked around and stuff like that. This is the first time back in the 80s, the mid-80s, that they actually published data on what the nerve structure looked like on the inside of the larynx. And as I told you, it pretty much divides into a closing nerve and an opening nerve. And so we did a study on dogs. And you might say, oh my God, you did it. These animals have given their life in so many instances so that people could lead better lives on Earth. And you know, we wouldn't have transplantation surgery. We wouldn't have so many things that have benefited the human race had we not been able to try this stuff out on animals first. You wouldn't have surgeons because surgeons need to practice their skills on animals. You can't practice cutting and tying on a computer, take my word for it. But what we found when we had dogs that we tried this type of operation on, which was basically to cut the nerves and reinnervate them, is that in the animals that didn't have the surgery, I could stimulate them. There we go. I could stimulate them all the way to a sound where they sounded very spastic. But actually, once we cut those nerves and reinnervated those nerves, I could stimulate them to the same level of input, but they never went into spasm. And so that gave me the first clues that maybe we could use this type of approach to help treat some patients with adductor spasmodic dysphonia. And you can see we published that all the way back in 1992, quite a while ago. And we looked at the way the vocal cords vibrated. And this is basically what the surgery looks like here. Through a little window, we find the nerve, we cut it, we pull the proximal end of the nerve out, and then we find another nerve called the ansa cervicalis, which is a nerve that goes to the strap muscles. And we take one of the branches of that and we graft it on so that it will actually grow into the larynx and do two things: prevent the muscle from atrophying and also prevent the old nerve from trying to grow back in. As I say to you, nerves like to regenerate and grow back together again. And so we try and reinnervate it to prevent those things from occurring. 93 were some of the first, back in 93, there were patients that couldn't get Botox. None of the patients that were at the county hospitals in Los Angeles were able to get Botox, and so there was no treatment for them at all. And so a couple of those patients underwent the first Denervation, Reinnervation surgery with pretty good results. And then 1999, because of Dr. Dito, we had to wait at least 3 to 5 years to present our results because his results of recurrences occurred after usually within 3 years. So anything that you publish about the treatment for spasmodic dysphonia had to really wait at least 3 to 5 years before you could say it actually worked or not. And there's kind of there's a larynx kind of turned on its side, and you can see the little nerve there in the window as well. Here's the nerve, and here's the little stellate configuration that it forms. So, the voice handicap index is a way of kind of judging how voices would be. And so for many of our first patients, we found that the average decrease was about 22 points. Anything greater than about 10 points is considered to be a significant thing. But some of these patients, not all of them, but some of these patients had pretty much normal voices, which was very encouraging to us. So at least 83% had a 10-point change. And these are just some of the pie graphs showing kind of where they started, and kind of where they ended up overall. I don't want to spend too much time on this. Again, these are just the scores that occurred. There's a couple patients down here that actually didn't get better. So when people ask me how successful is it, it's about 85% successful. There's about 15% that don't really respond. But the difference between that and the other procedures is you can go back to Botox shots. Nothing prevents you from re-Botoxing the patient if we don't get the results that we're hoping for. Not too many patients had spasms afterward. This is from the there were a few patients, men, that had very bad breathiness afterwards. And that was primarily related to, we didn't understand that, believe it or not, that there are differences between male and female larynxes. If you look at a female larynx, they oftentimes have a little chink in the back. It's just the way their larynx is, but they can still phonate because their vocal cords are small enough and light enough that they don't need that much pressure to get them vibrating. If men aren't able to totally close their vocal cords, they sometimes have difficulty speaking because they have much more massive vocal cords. And so now we've kind of altered the procedure so that we're sure that that's not going to happen to them. Universal doing bilateral. So patients usually have breathiness, and so they have dysphagia, swallowing liquids, just like a big Botox shot, for about 2 weeks usually after the surgery. But until the nerves grow in, which is about 3 to 4 months, they're pretty breathy. They're very breathy. They're really breathy. Some people just can't tolerate, 4 months of breathiness in their work. And so under those circumstances, we tried doing unilateral surgery, just like getting a unilateral Botox shot. But what we found, and it's probably the same thing that Dio found, because you're only treating one side, about 50% of the patients get a return of symptoms once healing actually occurs. And so they either have to go back to their shots or go back and have the other side done. It's not too bad if you're living close to UCLA to have the other side done, but if you're living on the other side of the United States, it's a big trek to come back all the way across the country to do that. So we typically don't advise it for patients unless they really have some other extenuating circumstance. It's like, I can't be breathy for that length of time. But I would say it works unilaterally about maybe 15, maybe 40% of the time. So who's a candidate? Pretty much the best candidates are patients that have spasmodic dysphonia. Some patients with spasmodic dysphonia have tremor, as we all know. They're not quite as good candidates, although some of them, the tremor is better, but others, the tremor really isn't all that much better. And it leads to, we're not 100% sure what we're doing. I know we're taking tension away from the larynx, but are we also cutting some of the affluence that are providing the somatosensory feedback to the larynx, nobody really knows, including Dr. Berke. And so there may be some other activities that are occurring that lead to the results that we're finding. Who's not a candidate? Mixed dystonias, which unfortunately probably a lot of you have because you're here and you haven't had very good results from standard therapy. And classic abductor dystonias that have difficulty closing their larynx. They're not good candidates also. I could play you a bunch of results that would sound great. Of course, anybody can play you results that sound great, so I'm not going to do that as well. But as I said, for about 85% of the patients, they find that their voices are adequate enough so that they don't have to go back to aftershock. Typical 1 month voices breathy, swallowing almost normal in 3 weeks. 3 months, still breathiness, 6 to 9 months stronger, and then 12 months maximal improvement is usually what we find. You know, nerves don't grow very well when you're past 65. So for patients that are in their later years, like me now, we're not as good candidates as we would have been if we were in our 50s to have something like this done. So my conclusions would be there's a number of manifestations of SD, and really the clinician's experience and diagnosis is paramount. And as I said before, a lot of you don't fit very neatly into some of the boxes that we tried to develop for this, and that's probably correct. Everybody's a little bit different, and the way that your larynx is responding to this neurologic disorder is different also. There's a variety of treatment options. I think Botox continues to be the best treatment for patients, and I never try and sell any type of operation to any patient that comes to see me. Adductor dystonia is a very difficult form of the dystonia to treat. Sometimes it can be treated by speech therapy, sometimes can help. Surgery to push the vocal cords together can help a little bit, and Botox can help as well. But it's not quite as easy to do as the other form. The treatment should be based on a number of factors, including the severity of your symptoms, your age, your health of the patient, their voice requirements. Everybody obviously needs their voice to communicate, but maybe you don't need the best voice in the room. Maybe your grandchildren still love you and will hug you when you see them, even though your voice isn't optimal for yourself. And there are technical concerns and training and experience of the treating physician that obviously come into play as well. So that's really all I have to say. I wish that I could spend a super amount of time answering questions and talking to you, but believe it or not, I have to catch an airplane. And I left Los Angeles at 3 o'clock in the morning yesterday, so I'm awake now.